Hi, good evening. Good evening once again. So today, I guess all the students have been following me. I'm not sure. So today I'm dealing with general orthopedics. Am I audible? Hello?
Yes, audible,
Okay, go
audible.
ahead. Okay, I will deal with general orthopedics today. Okay. So for general orthopedics, you should know orthopedics, of course, is both about traumatology and cold orthopedics. Fractures and cold orthopedics. We can't say cold, but it is non-traumatic entity. Non-traumatic. It can have malignancy, metabolic, and other disorders. I have dealt with malignancy, infection, pediatric, and other things, and miscellaneous disorders, metabolic disorders. Today, I will concentrate only on fractures, that too general management. General management. You get a lot of questions on general management of fracture also. Okay. So fractures are classified as closed fracture or open fractures. So depends on what, whether the skin over the fracture is breached or not, or whether the fracture ends or bone ends are in contact with the environment. So that is called as open fractures. Earlier it was called as compound fractures. Compound fracture, and closed was called as simple fracture. So these terminologies are not used anymore. Please remember, standard terminology is closed fracture, open fracture. Simple, the skin over the fracture is intact and skin over the fracture is breached, or where the bone ends are exposed to the bone. It is open, hence it is open fracture. So closed and open fracture. There is nothing much to discuss about closed fracture, but open fractures are further classified by, please remember this word, you will be frequently asked, Gustello-Anderson classification. Gustello-Anderson classification is used for open fractures. I will come to that in a minute. So Gustello-Anderson classification meant basically for open fracture. It was described for open fracture tibia. Please remember, it was described for open fracture tibia. Even now it holds good. For the only reason entire tibia is subcutaneous. Any simple fracture, it becomes open. So that's why it was described for open fracture tibia. Okay, Gustello-Anderson classification, please remember there are type 1, type 2 and type 3. 1, 2 and 3. Depending upon the severity of the soft tissue injury or the skin damage, please remember the Gustello-Anderson classification for open fracture depends on soft tissue injury. So 1, 2 and 3. 3 is further classified as A, A, B and C. Okay. So please remember there is a pictorial representation also here. See, grade 1, grade 2, grade 3. Please remember, listen carefully. It is very important. Invariably, they will ask you in one or the other MCQs. So how do you grade them? Type 1 Gustello-Anderson open fracture is less than 1 centimeter. So what factors are taken into consideration? The size of the wound. Listen carefully, this is important even for your university exam and most importantly for your NEET. So depends upon the size of the wound. Second is the contamination. Whenever see open fracture, why it is as good as an emergency is because once the fracture gets contaminated, infection chances are very high and fracture doesn't unite easily. So what it takes into consideration is size of the wound, contamination extent. You see open fracture where a lot of mud, wood pieces and gravel gets into the wound. Okay, so if the size of the wound is less than 1 centimeter, it is grade 1. To make it more simple, don't get into other things. So type 1 less than 1 centimeter. Type 2 1 to 10 centimeter is the wound size. Okay, type 3 it doesn't depend on the size of the wound. So if there is a periosteal stripping, it is type 3A. Soft tissue coverage required. 3B, significant periosteal stripping is there. So no confusion, please understand. Type 1 is less than 1, type 2 is 1 to 10 centimeter, type 3 periosteal stripping is minimal, type 3B significant periosteal stripping, and type 3C there is a vascular injury. Remember, so 3C is grievous or very urgent requirement for two reasons. It is an open fracture and second is vascular injury. So this is a dreaded emergency. Okay, to make it more simple, I have one more slide for you. Please remember, see, this slide appears little poor, but this helps you to remember 3ABC. 3ABC. A is what? Adequate soft tissue coverage is there. B is bad. C is circulation is impaired. So 1 and 2 you will easily remember. 1 is less than 1 centimeter. 2 is 1 to 10 centimeter size of the wound. 3ABC. 3A is adequate coverage, adequate soft tissue coverage. Please remember, already the skin is broken. B is bad. There is no adequate soft tissue coverage. C is circulation is impaired, means there is a vascular injury. Am I clear in this? Okay, so in treatment, before going to management of open fracture, please remember closed fractures can be treated. See, any treatment for that matter, you have conservative management or surgical management. Okay, see, what is important is closed fracture means you can treat conservatively, but again there are exceptions. So you can treat conservatively or surgically. But open fractures, so what are the goals, what are the principles of treatment of open fractures? All open fractures are assumed to be contaminated. So open fractures, why it is important is the hematoma, main healing driving force for fracture healing is fracture hematoma. So open fracture, there is always a delayed healing because in open fracture hematoma gets drained out completely. This is a main driving force for fracture healing. So there is always a delayed healing in open fracture because hematoma is disrupted. Okay, so what are the essential? So you assume the open fractures are contaminated unless proved otherwise. So what you have to do? You have to clean the wound. You have to thoroughly debride the wound. So contaminated wound is converted to clean wound to avoid the infection. So surgical debridement. See, surgical debridement can save tons of antibiotics. Okay, next step is you have to give adequate antibiotics. covering both gram-positive and gram-negative organisms. Even anaerobes also you have to cover. So once you debride it, you take it for surgery. Debridement is basically removing. You should know what is the meaning of debridement. Debridement is derived from word debrima or unburdle. Debrima means you have to remove the dead. You have to remove the debridement is you have to remove the dead necrotic tissue and remove the contamination. So it is basically you have to remove already dead or potentially dying, where you can have a secondary impact or second injury. So it has to be removed. So you do debridement is basically surgical debridement is remove the dead and necrotic tissue. Second is antibiotic prophylaxis. So after doing this, you have to stabilize the fracture. Stabilize the fracture is you immobilize the fracture. So fracture healing can happen only if the fracture ends are kept in alignment and it is immobilized. So it can be immobilized by splints, cast. I will explain each letter later. Each words: splint, cast, external fixator or internal fixator. So now you have seen that wound is clean and no chance of infection. Now the fracture also has to heal. So you have to stabilize the fracture. Okay. So once the fracture is stabilized, you have to cover the wound. This is where your plastic surgeon colleague will come in the picture. Okay. So this is why the open fractures are considered emergency. So in orthopedic emergencies are open fractures, vascular injuries, okay, and dislocations. These are orthopedic emergencies. Simple fracture can wait. You just immobilize because there is a lot of pain. Once you immobilize, the pain is taken care. They are not emergencies. You can plan the surgery very well. Okay, so one example I wanted to show. So open fracture tibia, once you have debrided, you have started antibiotics, you apply external fixator. External fixator. See, whatever the rods and plates are used, they are all used on outside the surface of the skin. So external fixator, again there are two types. Ring fixator, this is the ring fixator, and tubular fixator. See, these are tubes, these are steel tubes like flute. So it is a tubular fixator, this is a ring fixator. Ring fixator is also called as Ilizarov fixator. You should know this. Ilizarov fixator. ILIZARO is a Russian scientist or Russian doctor who has devised this fixator. So again, types of external fixator. It is very important. You can remember, it is very easy. Unilateral. See here the bone is on this side. Only one side that fixator is applied. Bilateral is bone is in the middle. Both sides the fixators are there. Bilateral. Multi-plane fixator. Look at this. It is in only one plane. Multi-plane fixator. Here it is in. This is coronal plane, this is a sagittal plane. So it is multiplanar fixator. These are all different types of fixators only. Okay. So this I was mentioning. This is in It looks in one plane. It looks in sagittal plane. This is, you don't classify uniplanar, multiplanar, unilateral, bilateral. Ring fixator is multiplanar, multidirectional. Okay. Ring fixator, I have explained already this. Okay. See, what is important is whenever we were talking about open fractures, invariably the stabilization or fixation of the fracture is by external only. External fixator. You don't put implants, rods or screws inside the body because the chances of infection is very high. So open fractures generally or most of the times we treat by external fixator. Please focus on this slide. See, the fixation of the fracture can be either internal fixation or external fixation. Okay. See, internal fixation is in the form of plate, or the rod is inside the medullary canal. It is a intramedullary, or this is extramedullary. So this is intramedullary, inside the medullary canal of the bone. This is extramedullary. Okay. So rods or nails are intramedullary, plates are extramedullary. So these are about internal fixation. This is only to make you help compare between the external fixator and internal fixator. As I was mentioning, I'm talking mainly about external fixator for open fractures. See, these are what I have described already. So what is the difference between internal and external fixation? You should know. So internal fixation is one of the method. It is one of the method for fixation of the fracture. External fixation will come to that later. So internal fixation can be done with various devices. See, like you want to write. So you can write with a pen, you can write with a pencil, you can write with chalkboard, you can write with, whole idea is you have to write. So whole idea here also is you have to fix it. Fixing can be, there are different devices. It can be pins. It can be pins. I'll come to that, explain you a little later. It can be rods and the nails, plate and screws, wires, and sometimes bone grafting. This fibula, what we take from the leg, can be used as a fixation device. So these are the different fixation devices. Okay. So in external fixator, I have already explained, will not get into that. So one more important thing what you should understand here is I have explained about the open fracture and closed fracture. Open fracture is Gustello-Anderson classification. So one more important thing is Winquist-Hansen's classification is for severity of the comminution. How much is the bone comminuted? Okay. So simple transfer, simple two-piece fracture which causes two segments of the bone is minimal comminution, Winquist 1. Less than 50%. See, if you measure this and divide into 2. See, it is less than 50%. It is Winquist 2. More than 50% Winquist 3. And almost 100%. See, the bone contact is not there. These are two main ends of the bone, but in between there is so much comminution, there is no bone contact here. So that is Winquist 4. these two things will not go. So please remember comminution. Comminution is how many pieces the bone is broken into is classified by Winquist-Hanson's classification. Okay. So whenever you see a fracture, you have to, the treatment starts whenever there is a patient with a fracture, the treatment starts at the accident site. Treatment is again extended in the casualty, and definitive management in the ward and operation theater. Remember this. So fracture, whenever you see on the roadside accident or a simple fall at home or simple fall from the height at the accident site, then comes your management in the casualty or accident and emergency ward and definitive management in the OT. Okay, so what is done in the site, whenever you see a patient with any kind of injury, fall from height or accident, motor vehicle accident, you see the limb is positioned okay. See, as I said, if you see a patient of an accident victim or a patient who has fallen down from height, if the limb is in abnormal position, you know for sure there is a fracture. There is a deformed limb. Limb is deformed placed in abnormal position. You know the shoulder cannot abduct, isn't it? Beyond 170 degrees. But still, if that patient is hand is going backwards, means it is abnormally moving. That time you should suspect a fracture. So what you do? You have to immobilize the patient. Immobilize the fracture. Immobilize the fracture. Okay, more important than that is you always use for all ABC. ABC is airway, breathing, circulation. You all see that the patient is not having any life-threatening injury or spinal injury in the form of cervical spine injury or anything else. So once these things are ruled out, the patient is ABC vitals are checked, they are normal, you immobilize the patient's limb. You immobilize the patient's limb so as to reduce the pain. So how do you immobilize the fractured limb? Whatever devices you use for immobilization of the fracture is called as splints. So roadside nothing can be available. Simple bamboo sticks, or you wrap it with a newspaper or your cardboard. You can use anything which is hard to immobilize the fracture. So they are also can be used as a temporary splint. They are temporary splint helpful for transportation of the patient. You have to transport the patient to the nearest medical facility. Okay, splints are the devices useful for immobilization or support a fracture in transportation or temporary management of the fracture. So the splints can be casts, spica, or the slab. Please remember, you always, if you are working in an orthopedic ward or you have already worked, you always see a patient with a white plaster, cast or slab. So you should differentiate between the cast and the slab. Is you don't know, because the white bandage is wrapped all around whenever you see a interesting Bollywood movie. So, but you should know what is the difference. If the POP, whatever we use normally is plaster of Paris. If entire thing entire limb is covered, entire circumference of the limb is covered by POP. So C for cast, C for circumference. So if this is a fracture, you completely put a POP bandage. You encircle completely with a POP bandage. It is cast. But if there is a fracture here and you immobilize only on the one surface, so it is a slab. Slab is only surface. S for yes. C for circumference. Okay, please remember this. Cast and slab. So whenever we are treating a fracture in emergency or temporary immobilization, you always put slab, because like this you put a slab. This is the axial section I'm talking. This is, say for example, a forearm bone with the radius and the ulna. You apply slab like this, because after injury there can be a lot of swelling. So if you put cast, there is something called as cast syndrome, which I will come to that in subsequent classes. So spica, again, one more important you remember about spica is this: whenever you immobilize the limb with the trunk, if you immobilize limb with the upper limb with the trunk or thoracic spine chest, if you immobilize lower limb with the abdomen, then it is called as spica. So cast here for cast, spica is spine. This is only mnemonic. There is no, this doesn't actually mean what is spica. Spica is to remember you are incorporating part of the body also to immobilize the limb, either it is upper or lower limb. So this is one more thing I was mentioning, Thomas splint. This is many such splints are available. Thomas splint is something you remember. Nowadays there are image based questions, which is a current trend. Please remember. Thomas splint has a ring. Thomas splint was devised by H.O. Thomas. H.O. Thomas. Hugh Owen Thomas. Please don't bother about the expansion. This is used for fracture shaft femur immobilization. So there are different things, we'll not get into that, but please remember it has a ring and two sidebars. This sidebar is basically to accommodate greater trochanter. There are different sizes available, and you place the limb like this and bandage all over so that you can transport easily to avoid fat embolism in a fractured femur. Okay, even though this slide appears little busy, but be careful to watch very closely about the different splints. Okay, volar splint. Volar is applied on the volar aspect of the forearm. Thumb spica, as I was mentioning, this is here the thumb is included with the forearm. Thumb spica. See, gutter splint. Gutter looks like this. This is on the ulnar side. This is ulnar gutter splint. Sugar tongue is what? Sugar tongue is what you use, like whatever you use to pick up sugar cubes. Okay, sugar tongue, I think you will not explain. Sugar tongs are basically, it is like a U-shaped device to pick up sugar cubes basically. Nowadays you see in hotels and restaurants to pick up ice cubes. So this is on both sides like this. Sugar tongue splint. So this is above elbow or long arm or long leg, means it is above elbow or above the knee. So it can be long arm, it can be long leg. Both are same. So stirrup splint for below knee, short arm, sugar tongue splint again, as I was mentioning earlier. So this is again the repetition of the slide, which was little better, but we'll skip this. Okay, one important slide the literature I found, Shin Splint. Remember, Shin Splint is not a splint. It is a disease entity. They might ask you a question to confuse. Shin is what? The anterior part of the tibia or the leg is called shin. This part of the tibia is called shin. Okay? This part of the leg, anterior surface of the leg is called as shin. You wear the guards for during the cricket match or during the football. Okay, so shin splints means it is basically pain in the anterior part of the leg. It can be anterior or it can be posterior, especially seen in people who are doing long distance running or marathoners or army recruits. Army, they are recruited to the army, which they are still finding it difficult to adjust. So pain in the leg after long distance running is called as shin splint. It is usually because of some minor fractures, which they are not detected on the X-ray. Okay, I was mentioning all the fractures can be treated with the cast, but there is an indication for surgery. When do you do operative treatment for the fractures? If it is an intra-articular fracture, if it is an open fracture, if it is if there is a vascular associated vascular or nerve injury. Closed fracture which is unstable. If you reduce the fracture closely without opening the fracture site, but it is again redisplacing. It is unstable. It is unstable. It is not maintaining the alignment. Then also you operate. Pathological fracture is generally secondary to metastasis or malignancy. If there is a lot of hemorrhage, polytrauma, if multiple fractures are there, better to fix so that nursing care can be improved. Early mobilization, people who are in a high profile job want to go to the office early instead of lying down on the bed for months together, you have to fix. These are the indications for operative management. Otherwise, you can treat the fractures conservatively. So we'll take some. I have today kept only a few MCQs this time. Okay. So please read the question. 37-year-old motorcyclist presents to emergency department after being involved in a road traffic accident. He has sustained displaced femoral neck fracture. Remember this. Femur neck fracture is there and it is displaced. What is the most appropriate form of the management? Okay, so you take into the consideration of the age of the patient and the type of the fracture. So what is the age of the patient? 37 means he is young and the fracture is fracture neck femur. So remember, I have told even in my previous classes, these are fractures of necessity. And fracture neck indication for surgery, I told you, it is again an intra-articular fracture. So operative management is must. Okay, so fractures of necessity is, this is an intra-articular, you have to fix, and the patient is young. So what you want to do? You want to do a total hip replacement. Anybody wants to answer this? Hello? Okay, so see, whether you want to replace, whether you want to reduce because it is displaced. Displaced means you have to reduce and fix it. Or you have to do a hemiarthroplasty. So one option is total hip arthroplasty, hemiarthroplasty, fix it. So cemented, uncemented, don't bother. There is again hemiarthroplasty, intramedullary nailing. So please remember, the patient is young. So you have to restore or retain his original femoral head. So better is to reduce and fix it. You know, the fracture of the neck of femur is classified into by Gardens or Powell's angle. So more the displacement, more is the chances. Most common complication of fracture neck femur is AVN and non-union. So please remember, patient is young, you have to fix it. If the patient was old, you can do hemiarthroplasty. If the patient is more than 60 years, you can do hemiarthroplasty. So it can be cemented or uncemented depending upon the bone quality. So what we are interested in is more than 60 years, you want to make the patient up and above so that as early as the patient can be mobilized to prevent hypostatic pneumonia and bed sores, you can do replacement. Okay, but in young patient, it has to be fixed. So when do you do total hip replacement? If the patient is much older than 60 years, and if the acetabulum side there is arthritis, if there is arthritis on the acetabular side, so you have to do a total hip replacement. Answer for the patient, young patient with fracture neck femur, in a nutshell, the treatment is reduce and internally fix it. With cannulated screw fixation of fracture neck femur, so I told you reduce and fix it. Now how do you fix it? I will explain that in a minute. So cannulated screw fixation of femoral neck fracture with which following complication is an entry point below the lesser trochanter. So it is difficult for you to answer, but these are all potential questions, I'm sure. So you understand the fracture neck femur. I'll draw a picture here. There is a fracture here. Okay, you have reduced it. So how do they fix the fracture neck femur is you put 3 screws. You put 3 screws. These are the threads. They have to be kept put in a inverted triangle shape. If you see from the side, there's one more screw here, one screw here, one screw here. So inverted triangle if you see from the side. So this is how you do it. There is a lesser trochanter here. So if you put the screw like this, what will happen? So if you entry point below the lesser trochanter. So if this here is the entry point for these screws. If your entry point is made below the lesser trochanter, what is the common complication is subtrochanteric fracture. Please remember this. So most important factor in fracture healing. You have to remember there is something called as Lamberti principles. Lamberti principles for fracture healing. Okay, so all the factors are essential for fracture healing. See, good alignment, organization of blood clot, as I said, closed fracture heal better or earlier than open fracture is one because of organization, and accurate reduction and 100% opposition of the fractured fragment, immobilization, adequate calcium intake. See, read the question very carefully. Most important factor. All these are important factors, or all these factors are essential for fracture healing. Most important is immobilization. You have to immobilize. A fracture will heal only if it is immobilized. In most places, a simple alignment also it heals. Open fracture also will heal. So adequate calcium intake, yes, it is essential. Most important factor for fracture healing is immobilization. Please remember that. See, whenever we are talking of fracture, we invariably talk of fixation of the fracture. We want to fix any fracture for that matter, we want to fix or replace it. So the treatment of fracture is either you fix or replace. But in certain situation, the fragment is excised. So any fracture for that matter, you fix or you replace. It is like any mobile device, isn't it? If it is either it can be repaired or replaced. So, but in some situation, fractured fragment excision is done. Okay? Excision of fractured fragment is practiced in all fractures except, okay, patella. See, patella I have covered in my previous topic. Patella can be a simple transverse fracture or a stellate comminuted fracture, or there is a polar fracture. There can be various geometries, shapes of the fracture. But so patella fracture, olecranon fracture again, see, olecranon fracture, head of the radius, again head of the radius, lateral condyle of the humerus. Okay, see, we'll go one by one. If there is a small piece of the head fracture, you will excise. So this is correct. Olecranon, again, if there is small fracture, you excise, you don't fix it. If it is not compromising the elbow stability, if by removing this bone and you repair triceps, you are not compromising the elbow stability, you excise. So olecranon is correct. In patella again, if there is a small bone here, there is a small piece fractured, you can excise and repair the quadriceps. So, for all practical purposes, patella and olecranon behave same. Here triceps is attached, here quadriceps is attached. Here it helps in extension, knee extension, here it helps in elbow extension. So all practical purposes, small fractures of patella can be excised, small fractures of olecranon can be excised, head of the radius, if it is small, can be excised. Lateral condyle of humerus is the answer. You cannot excise the lateral condyle of humerus. You have to fix it. You, no matter how small it is, even if it is very, very small, because the lateral collateral ligament is attached, which has very, very essential for stability, you have to fix it. See, one more important thing, Kwire is used in. See, I will describe something about Kwire in a while. See, Kwire is used in cerclage, fixing of the forearm bones prior to the plating, all of the above. Answer is all of the above. Okay, so please remember, Kwire is the most versatile device for fixation. They come in from 1 millimeter to 3 millimeter. They are pointed tip on both ends. You should know this K wire. K stands for Kirschner wire. Kirschner wire. Okay. Again, anything more than 3 mm and stiff, you get Steinmann pin. Steinmann pin. Steinmann pin is used for traction, skeletal traction. K wire is used for fixation of any fracture. If the fragment is small, especially in children, and it is a smooth K wire, or there can be a threaded K wire. Most commonly it is used for a supracondylar fracture of the humerus in children. Say for example, there is a fracture like this. There is a fracture here. You put a K wire like this. Cross K wire pinning for a supracondylar wires. And similarly, while doing surgery for temporary holding, when there is a lack of assistance, you do again use the K wire. Open reduction in children is done in. See, you remember, most of the childhood fractures or pediatric fractures can be treated conservatively. More than 90% of the fractures in children can be treated conservatively. Remember this. When open reduction is required. Why conservatively is? Because there is a good remodeling potential. So, but still the exception for this are certain fractures. So open reduction in children is done for which fractures? Look at this. Supracondylar fracture, forearm both bones, femoral condyle or lateral condyle. So I'll answer this for you. Supracondylar fracture, I showed a diagram. Forearm both bones, again you put a above elbow POP cast. You can fracture will heal. Similarly, femoral condyle, you can do a close reduction and put a cast. Lateral condyle humerus also is one where you have to do a open reduction. The reason being, lateral condyle, see, this is a, or it gives origin for common extensors. Common extensors. All the muscles are lateral, originating from lateral epicondyle. So any fracture, if this gets displaced. If the fracture gets displaced, it will never heal. You have to reduce it, and you have to reduce and maintain in that position. That's why the lateral condyle of humerus fracture requires a open reduction. A segmental tibia fracture with 1 centimeter skin. Yeah, please, anybody answer this question because I have covered in the text.
Type 2.
Yes?
Type 2.
Type
2.
why 2?
1 to 10 centimeters.
Yeah. The question again, the problem, it can be both 1 or 2. It is less than 1 or less than 1 and 1 to 10 centimeters. Okay, but for all technical reasons, this is type 1. Is this Roshan?
Mohan,
Type 1
sir.
is answer. Rohan, okay, good. So here type 1 is answer. Please go and read carefully. 1 and less than 1 centimeter, it is type 1 Gastillo-Anderson class open fractures. Okay. Steinman pin, I did mention in the past slide. Steinman pin is used for all except, see, please remember, Steinman pin is used for skeletal traction. Skeletal traction. See, traction is what? Traction is you have to pull. You have to keep the fractured end pulled, because if they rub against each other, it causes pain. You have to keep it distracted. You will use a traction. So you can use a skin traction or you can use a skeletal traction. Pay attention. Skin traction is you distal part of the fracture, you apply over the skin some bandage and put weight. You put some weight. This is skin traction. But if you are putting a skeletal traction, you have to put a rod here through and through. You have to put a rod through and through and apply the rope, apply the weight across the pulley. So you can put more weight. Skin traction can tolerate up to 4 kgs weight. Skeletal up to 10% of the body weight. 10% of the body weight. So suppose if the patient is about 80 kgs, you can put up to 8 kgs. Up to 10 kgs you can put. So when you require heavy traction, heavy weight to pull the fracture ends, you use the skeletal traction. Skeletal traction, what are the things what you are using is Steinman pin. What I mentioned is, it is a Steinman pin like this. So what you do, this is a lower end of tibia, you put pin like this, and there is a U-shaped bowler stirrup. Please remember this. This is very, very often asked bowler stirrup. So there is a, you put a rope and put a weight across the pulley. So there is a fracture end here. So why? Because if the fracture doesn't stay like this, after the fracture there can be overlap. So you have to pull it by skeletal traction. So for skeletal traction, you use a Steinman pin. Of course, Kwire is also used. Most commonly, Steinman pin is used. So Steinman pin is used for all except upper end of tibia, lower end of tibia, lower end of femur, skull traction. So answer is self-explanatory. If somebody can take, it will be good. Rohan. See, I did draw the diagram, isn't it? So the pin has to go through and through the bone, which is certainly not possible in the skull. So answer is skull. Skull you are using. So even in skull also we are using skeletal traction, wherein it is called as Crutchfield tongs. Sugar tong, what I mentioned. Similarly, there is small pin which enters about 3 to 4 mm into the skull, outer skull. This is called as, please remember, Crutchfield. Crutchfield is the name of the person, tongs, like a sugar tong. So, Steinman pin definitely you can't drive through the brain, isn't it? Okay. So that's all for today. Apparently, major topics I have covered. If students are following since beginning, so I am just picking up random topics. So